Hello, everyone. Happy evening. A very good evening. I hope and I believe all of you are doing well. And thank you so much for all the love. I was seeing the chat there, and it's a great honor to be associated with PrepLadder. And I would be your radiology faculty on this esteemed platform of PrepLadder. So thank you so much again. And in the today's session, we are going to have the final run for the FMG exam. This is, of course, going to help the NEET PG, the INI-CET students as well. And I have tried to include everything possible and the most important that is expected in the upcoming FMG exam. So you have to revise this session one day prior to exam as well, because as my instinct says that you would see a lot of images from this appearing in your exam. So make sure you have all these images on the tip of your tongue. Right. So I believe we are good to go, and the audio visual is all good. A quick nod, everyone in the live chat. Thank you so much, Amritansh, Sukhbir, P, and everyone. Thank you so much for that. Okay, so let's start with the discussion. And this outline is not to scare you all, guys, but this is to tell you that this session is going to be all comprehensive and exhaustive, covering all the systems. So I have handpicked the most important 4 to 5 images from each system, including anatomy, the identification of investigations, the various systems, the NMRT, the general part, all of that. Okay, so we are going to cater to each system step by step, so that you get to know which are the most important images. Yes, Ayushi, this would be available for viewing later as well. All right. So let's start with the most important images in anatomy. Right. So the question here is, the labeled structure is which of the following? Which is the label structure here? This is the label structure here that we are seeing, right? So what is this label structure? Is it caudate, putamen, globus, thalamus, or is it insula? Great. Majority of you are getting this right. So this is thalamus. Okay, this is thalamus. Let me quickly tell you the anatomy here. First of all, this is MRI. It's a T1 weighted MRI. We are going to see why this is T1 weighted MRI as well in the upcoming images. So this structure here, this is the frontal horn of the lateral ventricle. If I draw the schematic diagram, we have the frontal horn of the lateral ventricle. Adjacent to that, the basal ganglia that we have, that is caudate. Now these lateral ventricles, they open into the third ventricle by the foramen of Monro. Right. So this is the third ventricle, right in the midline, the slit-like structure. So basically, this is where we would see the third ventricle. On either side of third ventricle, remember TH, TH, and TH. That is third ventricle ke aju baju. We have the thalamus. Okay, so that is this structure here that is labeled. This is thalamus on either side of third ventricle. Now, what do we have next is, in this caudothalamic groove, this is where we will have the V-shaped white matter tract, that is internal capsule. Okay, that is internal capsule. Now, lateral to internal capsule, we have the lentiform nucleus, the medial part of which is globus, and the lateral part is putamen. So globus pallidus and putamen, which together form the lentiform nucleus. Okay, they form the lentiform nucleus. And lateral to the lentiform, this part of the brain that we are seeing, this cortex that we are seeing, which is the island of the brain, this is called as insula, a frequently asked question, a previously asked question with the cadaveric section as well. Okay, so this is the insula. So the label structure here, because it is on either side of the third ventricle, remember the third TH, 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 this is the thalamus. Okay, this is thalamus. And this structure here, the white matter tract that we are seeing connecting the two hemispheres, this is corpus callosum. Okay, this is corpus callosum. So what is the label structure here? The label structure here is thalamus. Going one step ahead, since we are at thalamus, can you tell me that if you see bilateral thalamic hyperdensities in a child, what sphingolipidosis do you think of? So integrating this radiology with pediatrics, with biochemistry. So tell me that bilateral thalamic hyperdensities would be which sphingolipidosis? That is going to be Krabs disease. Okay, that is going to be Krabs. That's going to be Krabs. All right. Let's go to this image here, a quick review of what we have seen. So joining the two hemispheres, this is the corpus callosum. This is the frontal horn of lateral ventricle. And adjacent to that, we have the caudate. This is the third ventricle. Adjacent to that is thalamus. Adjacent to that is thalamus. The V-shaped white matter tract, that's going to be the internal capsule. And lateral to that is lentiform nucleus. And the part of the brain here, this is insula. Okay, that is insula. Clear with everyone? Let's go on to the next image in anatomy, because this has been asked in the NEET PG previously. So FMG students, whatever other NEET PG questions, it is important for FMG. Vice versa, whatever other FMG PYQs, they are important for NEET PG as well. Right. So easy one. This is cerebellum. Okay, this is cerebellum. This is a CT or a MRI. Just adjacent to the brain parenchyma, we are seeing the black line just outside. Do not get confused by this white line. Just outside the brain parenchyma, there is black line. That's the black bone. So this is MRI. This structure here, this is the corpus callosum. Okay, that's the corpus callosum. And this white matter relation to the corpus callosum, this is the fornix. Okay, that's the fornix that we are seeing there. What is this triangular structure here? This triangular structure here, this is the fourth ventricle. Okay, this is the fourth ventricle. And this is pons, the midbrain, pons, and medulla. Okay, the midbrain, pons, and medulla. So remember, this is the anatomy here on the sagittal section. Now tell me this one. What do you think is this labeled structure here, which is shown in this MRI? What is this labeled structure here? I hope all of you are able to see this. I'll zoom in this image for viewing it better. Very good. Alia, absolutely right. Yes, Sayanthan, and that is thalamus. So this rounded structure, which is on the either side of third ventricle. Now, where is the third ventricle? This is the area of lateral ventricle. This is where the foramen of Monro would be, and this would be the area of the third ventricle, right? So third ventricle ke aaju baaju mein, the structure that we would see, that is going to be thalamus. Okay, that is going to be thalamus. And this one here, the structure that you would see, that thin duct-like thing going to the midbrain, that is the aqueduct of Sylvius. So remember that aqueduct of Sylvius is the cavity of the midbrain, connecting the third ventricle to the fourth ventricle. That's the aqueduct of Sylvius, and that's the thalamus that we have seen in this image, right? Now, and what is this rounded structure here in front of the midbrain? What is this rounded structure here? This rounded structure here in front of the midbrain, it is anterior to the midbrain. That is mammillary body. Okay, remember that is mammillary body, guys. That's not the pineal gland. MB, mammillary body, is in front of MB. That's the midbrain. Where is the location of the pineal gland? Pineal gland, the relation to the third ventricle is posterior. So posterior wall of the third ventricle below the corpus callosum, this is where would be the location of the pineal gland. That is where the location of pineal gland would be. And always remember this point, whenever you have the involvement of mammillary body, and if it's an alcoholic patient, what diagnosis do you think of? Alcoholic patient showing abnormal signal in mammillary body. What diagnosis do you think of? That is Wernicke's encephalopathy. Absolutely right. That's Wernicke's, which will have the triad of Goa, thymine deficiency. FMD students, this is very important question for you from biochemistry as well. Wernicke's is confusion, global confusion, ophthalmoplegia, and ataxia, vitamin B1 deficiency, thymine deficiency, right? So that is about this one. Now going to the next set of images in radio anatomy. Tell me, what is this label structure? Let's see who gets it right the first. What is this label structure here? How long this session will be till we are able to complete all the images, targeting at somewhere between 1 to 1.5 hours. Yes, this is a pulmonary artery, correct. This is the CT scan with the white bone. This is the aorta with the white contrast. So CT scan with the white contrast, that is contrast enhanced CT. These are the black air containing lungs. So the structures in the chest, in the mediastinum, the three major structures which you see here. So always remember in radiology that your left is the patient's right Okay, your left is the patient's right and your right is the patient's left. So the arrangement of the structures is SAP, that is from right to left. It is superior vena cava, AA is ascending aorta, and the leftmost one is the main pulmonary trunk, which is dividing into this right pulmonary artery and the left pulmonary artery. You see the main dividing into the right and the left. Okay, so this is the main pulmonary trunk that we are seeing here. This is a previously asked question in the FMGE exam. You would see in your books as well. What is this structure behind this pulmonary artery? What is this structure behind the pulmonary artery here? This one is black. Remember that black on CT, black on X-ray is air. So this is air containing bronchus. Okay, that's the bronchus going along with the pulmonary artery. That's the bronchus. So the right bronchus, this is the right bronchus. This is the left bronchus here. Okay, the right bronchus and the left bronchus. Going on to the next image here. First, identify the investigation. What do you think is this investigation here? So this image, what do you think is the investigation here? This is angiography first of all, right? Because you see the vessels, so you know that it's angiography. Are we seeing only one side vessels, Kirti? Are we seeing only the right side or the left side? Thank you so much, Devtaru. Thank you for that. We are seeing both the side ke vessels. DSA, digital subtraction angiography, is done by putting the catheter into the artery. It's one side at a time, one vessel at a time, and its branches. We are seeing both sides. Both sides means it's a cross-sectional imaging. That means either CT angio or MR angio. Now, since we are not seeing the white bones, the white bones are not seen here. That is why this is not CT angio. So this becomes MR angio. Right. Another important point generally for your exam, remember that DSA would be with black vessel. So any angiography where you see that the vessel is appearing black, it has to be DSA and no other angiography, because CT angio, MR angio will always be white. DSA can have black vessel or white vessel, but DSA is the only one that will have the black vessel. So whenever you have an angiography with black vessel, remember that it's DSA, right? So identifying the structures here in MR angio. These two vessels which are joining to form one vessel, which is that vessel in the brain, that is vertebral artery, vertebral artery. The two vertebral arteries, they join to form the two vertebral arteries, they join to form the basilar artery. Okay, they join to form basilar artery. What is the terminal branch of the basilar artery? Piche, posterior circulation. So that's the posterior cerebral artery. That's the PCA. Coming to the anterior circulation, this tortuous vessel here supplying the brain, that is the internal carotid artery. What are the terminal branches of internal carotid? One going aage, anterior aage wala is anterior cerebral artery. Lateral wala, which is in between the anterior and posterior, that is the middle cerebral artery. Right, so ACA and MCA is from ICA, and we have the PCA from the basilar artery. Right? Is this clear with everyone? So these are the various vessels that we are seeing in this image, correct? Now, going to this image that has been asked in the previous exam. What do you think is this label structure here? This is MRI with the black bone. The water is white, a T2 weighted MRI showing this structure. This is midbrain. Is it midbrain? Is it pons? Is it medulla? Remember that this one here is midbrain. If you correlate it with the cadaveric images, the classical shape here, which is that Mickey Mouse shape or the heart shape, that Mickey Mouse or heart shape wala is going to be midbrain. Okay, that's going to be midbrain. So this is the midbrain. Always remember the shape. Okay, that's the midbrain. All right. Going to the next image here. The next image here, this is the CT scan because the bone is white. And we see that it's a contrast CT that we are seeing. So what are we seeing here is, let's identify the structures. This is the right side of the patient. This is the left side of the patient. So on the right side, we have liver. So what is this structure here, which is adjacent to the liver and it is having this gray appearance? What is this structure here? adjacent to the liver and the gray appearance? Right, that is gallbladder. Why is the gallbladder gray? Because fluid water is gray on CT. Water is gray on CT. So that's the gallbladder. This one here labeled, it is stomach. The black is the air in the stomach, right? Behind the stomach, in the stomach bed, this structure that we have, which goes from the right side to the left side and going to the spleen. What goes towards the splenic hilum? This is going to be pancreas. Okay, that is pancreas there. This is the aorta on the right side. Okay, this is the, just give me a minute where I lost this image, right? So this one here, this is the aorta here on the left side. Aorta, and what is this to the right of the aorta? This has been asked in previous NEET PG exam. To the right of the aorta will be the vein that is IVC. Okay, so this is going to be inferior vena cava. So this one here, remember, is inferior vena cava to the right of the aorta. That's the inferior vena cava, right? And can someone identify the structure for me? Can you see this small structure here on both sides? One, this on the left and this on the right. Posterior to the IVC, you can see that small structure. What is that small structure there? Behind the IVC on the right side, very good meat, very good Sayantan medic, that is adrenal. The small structures, those you see here, the Y shape or the V shape, those are the adrenals. Okay, those are the adrenals. Look at the relation of adrenal on the right side. It's behind the IVC. Okay, it's behind the IVC. This vein, the vessel which will be formed here, related to the pancreas, this is where the portal vein will be formed. The confluence of the portal vein, right? The portal vein will be formed here by the joining of the splenic vein and the superior mesenteric vein. This is going to be portal vein, right? So let's go on to the next image here. Even this has been asked. How do you differentiate colon from small intestine on abdominal X-ray? Is by the presence of haustra in the colon and by the presence of volvulae conniventus in the small intestine. What is the difference? In the colon, the haustrations which are present, they are incomplete projections. The small intestine, the volvulae conniventus, these are complete rings. Okay, these are complete rings. So like you look at this image here, this bowel containing air, you can see the incomplete projections. So those are the haustrations, do not traverse the bowel. This is large bowel. This one here, this bowel loop that we see here, it has these complete rings. That is the volvulae conniventus. So this is the small bowel. This has been asked in one of the recent NEET PG exams in the last 2 years. So this is jejunum. The question was identify what bowel loop it is. Jejunum, it has the maximum volvulae conniventus. Okay, it has maximum volvulae conniventus, right? Going to next one of the recent FMG exam question, identifying the tarsal bones, identification of navicular bone was asked. Navicular bone, how do you identify? So what do we need to see here is, if we look at this lateral image here first. So this bone here, we will have tibia and fibula here. The bone which is forming the dome of the ankle, which is participating in the ankle, that is what bone? The tarsal bone participating in the ankle joint formation. This is going to be talus. Okay, that's going to be talus. Next, what is the bone forming the heel? This is going to be calcaneum. Okay, this is going to be calcaneum. So talus, calcaneum. We have talocalcaneum navicular joint. So in association with talus and calcaneum, unke aage jo hai, that is going to be navicular. So on the lateral radiograph, this is the navicular bone here. Okay, this is the navicular calcaneum, and here we have talus. Here we have talus. What kind of joint is this talocalcaneum navicular joint, guys? That is a ball and socket type of joint, right? This is the mnemonic. In this, the T stands for talocalcaneum navicular joint. So that is talocalcaneum navicular. In this oblique radiograph that we have for the lower limb, what are we seeing here? The heel wala bone, this will be calcaneum. The bone articulating with tibia, that's going to be the talus. And talus ke aage nav shape, boat shape, nav is navicular. So that is nav shape, boat shape is going to be navicular. So this is where we are seeing the navicular. Calcaneum ke aage would be cuboid. So fifth metatarsal ke baaju mein, the tarsal bone that we have, that is cuboid, and the rest of the three are the cuneiforms. right? So this is cuboid on the lateral side, calcaneum on the lateral side there. We have navicular here, then we have the talus there. Okay? The same thing which is depicted here in this image here. What are we seeing here is this bone here, which is going to be nav shape, that is navicular. Lateral side, fifth metatarsal ke baaju mein, that's going to be cuboid. Okay, that's going to be cuboid, right? So that was about anatomy part. Now going to the identifying the investigations. PET-CT has been asked in the recent exam. It has been asked previously in FMG and now recently in NEET PG as well. Identifying the investigations. So all of you, please give me a thumbs up if everybody is done with the anatomy part, whatever we have discussed so far. Right, so those are the most important anatomy images. Okay, those are the most important anatomy images. Thumbs up not only here in the live chat, but also on the video. So that's a permanent thumbs up that I have, right? Okay, so let's go on to the next one. What do we have in the next images? Identifying the investigations. The first one here, this is MRCP. Why MRCP? MRCP is magnetic resonance cholangiopancreaticography. So we see the cholangio and the pancreatico, that is the CBD here and the pancreatic duct here. CBD and pancreatic duct. This fluid containing structure here, this is gallbladder. So this is MRCP. Why this is not ERCP? ERCP is endoscopic retrograde cholangiopancreatico. So we should see the endoscope in ERCP. There would be that endoscope that we would see in ERCP. We are not seeing the endoscope here. That is why this is MRCP. Previously asked question, what MRI sequence is MRCP? It is a heavily T2 weighted MRI sequence. Because in T2 weighted, water is white. We want to see the water in the bile duct, the bile, the pancreatic juice. So we want the water white, and that is why it's a T2 weighted MRI. Remember, it's a T2 weighted MRI, right? Next one, what is this investigation? Is it a CT or a MRI? Always we tend to get confused. But remember that what you need to check is just outside the brain parenchyma, the black line that we have, that is the bone. If we have the bone black, then it is MRI. Please do not get confused with this white line outside. That is the fat which is white on MRI. It's a scalp fat. You have to check just outside the brain parenchyma to look for that black line. What MRI sequence is this? It is a T2 weighted MRI with the water white, World War II. Let's have a quick look at the MRI sequences. To identify the MRI sequences, the first is look at the water. If the water is white, that means World War, water white, that is T2. If the water is black, that means the water is not white. The next thing that we need to look at is the white matter. Okay, the next thing that we need to look at is white matter. Now, if the white matter is white, okay, if the white matter is white, that means anatomy is being followed. White is white, gray matter is gray. Anatomy is your first year subject, first year MBBS. So remember that it's a T1, first year T1 MRI. Okay. Then if the white matter is also black, that means the water is black, the white matter is also black. That means it is all black. So it is going to be flare. Remember that flare is all black. That is all you need to remember here. Water white is T2. White matter white is T1 and all black is flare. Implementing in these images, image 1, image 2 and image 3. Out of the 3 images, the one image that we are seeing the white water. What is the water in the brain? CSF. So I'm seeing the white CSF in the ventricles. So this is T2 weighted MRI. Here the water is black, here the water is black. Next, which is the white matter? I can see the corpus callosum here, the corpus callosum here. This is the corpus callosum here. Here the corpus callosum is white. Here the corpus callosum is black. That means white matter is white here. So this is T1, anatomy being followed. Here the water is also black. The white matter is also black. All black is going to be flare. Okay, all black is going to be flare. So that's the flare sequence there. So going back to our previous image that we had. So this one is water white, and that is why this is going to be T2 weighted MRI. Okay, it's a T2 weighted MRI. What is this one? This was the recent question, like I said, was asked in the exam. So this is the white bone. That means it's a CT scan, but it's not just black and white. There's a color added to it. Okay, there's a color added to it, the orange color. So when you see the orange colored CT image, remember that it is PET CT image. PET combined with CT, previously asked FMG exam question. It's an example of fusion or hybrid imaging. It's an example of fusion or hybrid imaging. ठीक है? PET का question आया था FMG में. What isotope do we use in PET? It is F18, fluorine 18, because it is FDG PET, which is the most common. So remember, that's F18. What is the half-life of F18? It is around 100 minutes. A previously asked DIP mark question. It is around 100 minutes, that is 2 hours. Okay, diagnostic hai. 2 hours is good enough to complete the scan. Okay. Next one, what do you think is this image now? This ultrasound image that you are seeing, guys. Let's focus on the next image here. Give me a minute. I hope all of you are able to see the image. This one is a routine ultrasound. But what is this when you see the orange colored ultrasound? Colored ultrasound, there's no investigation like colored ultrasound. See, orange CT is a PET CT. Orange ultrasound is not a PET ultrasound. This is not a Doppler. Right, Nazish, this is not a Doppler because Doppler is for blood vessels. You are not just seeing the blood vessels colorful here. It's the entire black and white image which has become orange color here. In Doppler, remember, it is for blood vessels. So in Doppler, it is the vessels which will show the color. Okay, the vessels will show the color, not the entire image. Right. So this is contrast enhanced ultrasound. Orange colored ultrasound image is a contrast enhanced ultrasound. What is the contrast used in ultrasound? It is micro bubbles. Micro bubbles are used as ultrasound contrast. Okay, remember that. Next one. This is also a previously asked image. What investigation is this? Now what you see here, this white color, this is the endoscope. So this is endoscopic. We are seeing the CBD here and we are seeing the pancreatic duct here. So this is ERCP. Okay, this one is ERCP where we see the endoscope. Remember that this image can come as a black colored image as well because it's done under fluoroscopy where you can see the contrast, like I said in DSA, it can be black, it can be white. So any investigation done under fluoroscopy, it can be black or it can be white. Okay, this is ERCP. What is the advantage with ERCP? What is the advantage with ERCP? It is therapeutic as well. Even though it is invasive, but that gives an advantage as well. That means it is therapeutic as well. Okay, that's therapeutic as well. So generally, ERCP is the gold standard for the biliary pathologies. Gold standard investigations are generally the last resort. The invasive ones are the gold standard generally. Okay? All right. So going to the next image here. What are these investigations? Again, this has been asked in the NEET PG exam also previously. What is this? It's a barium study. Is it barium swallow, barium meal follow through, or it is enteroclysis, or it is barium enema? So where you see the barium in the stomach, that tells you that the barium has been given orally. That's why it has come in the stomach, right? In contrast, this one, where you don't see the barium in the stomach, that means oral nahi diya gaya, rectal diya gaya hai. So the last one is barium enema, where you see the hostrations of the colon, the barium from the rectum. This one, where we see those valvulae conniventus, that gives the feathery appearance here. The small bowel loops are entirely seen, the jejunum, the ileal loops in the pelvis. This is for the small intestine. This is barium meal follow through, which is for small intestine. Why this is not enteroclysis? Now, what is enteroclysis? Enteroclysis is basically small bowel enema. That means we put the tube, the nasojejunal tube, And then through that tube, we put the contrast. That means directly into the jejunum. So that bypasses the stomach. The contrast will not be in the stomach. And you would see this tube-like structure here. You would see the tube coming like from the stomach into the duodenum, into the jejunum. So if you see the tube is present, then it is enteroclysis. Okay, then it is enteroclysis. Generally, we don't do enteroclysis now. Now, for the small intestine mucosal pathologies, the investigation that we do is CT or MR enterography. Okay, CT or MR enterography is done for the mucosal pathologies now. Okay, and the last one is the barium enema, where you don't see any barium in the small intestine, in the stomach, that is barium enema, right? This was also asked in the recent exam, one of the recent exam, the NEET PG exam, I believe, or the INI-CET exam. What investigation is this? Absolutely right. This is Doppler. Okay, this is Doppler. The options given were like, is it plethysmography, and other options were given. Remember that where you see the waveform like this, it tells you the flow direction. That is Doppler. It's not an ECG. Okay, remember that this is not an ECG. This is Doppler, okay, which is basically for the blood flow. It shows the direction of the blood flow. The velocity of the blood flow can also be measured. It's a Doppler image, right? So that was about investigation. So we are done with anatomy and investigations. Now coming to the next system, that is neuroradiology. Okay, neuroradiology. Now in neuroradiology, very, very important knowing all the hemorrhages. So this one, first of all, it's a CT. This pathology here, this is hyperdense. Always remember in radiology that hyper means white and hypo means dark. This is white, so that means this is acute hemorrhage. Acute hemorrhage is hyperdense on CT, not chronic hemorrhage, right? And this one is the biconvex shape. The biconvex shape that is limited by the sutures, that is EDH, which is idly shape like this. That's EDH. It's rupture of MMA. We see the lucid interval. Remember, lucid ED. Lucid interval is seen in EDH. Again, a recently asked question, right? What is this image showing? In the CT scan, those multiple white areas. This is starry sky appearance. Okay, that's the starry sky appearance, which is all the calcifications, the scattered calcifications. That is neurocysticercosis. Okay, that is NCC, neurocysticercosis, starry sky appearance, right? Starry sky appearance, Burkitt's lymphoma. Starry sky appearance in the kidney, immunofluorescence is PSGN. Remember all the starry sky. This one here again, tell me what is this? Is this infarct? Is it acute hemorrhage? Is it chronic hemorrhage? This one again is a CT. White on CT is either calcification or acute hemorrhage. So this is acute hemorrhage, which is intraparenchymal, which is within the parenchyma. So this is acute intraparenchymal hemorrhage, which has this intraventricular extension also, which is extending into the ventricles as well. Most common cause hypertension, most common site putamen, right? And this one here in this image, a very well-defined, will I call it a hyperdensity or a hypodensity, guys? As compared to the rest of the brain parenchyma, how is that? Is it hypodense or hyperdense? It is hypodense. It is darker, so it's hypodense. Hypodense, very well defined, involving the cortex also. That's the gray matter also gone, the cells also gone. So this is an infarct. Remember, this is an infarct, previously asked question. What territory infarct is this? This is the middle cerebral artery. Okay, this is the middle cerebral artery. So aage wala is ACA territory, piche wala is PCA territory. So this is right MCA infarct. The patient will present with left hemiplegia. The patient will present with left hemiplegia. Okay. So look at this one, very, very important. Infarct is hypodense. Hemorrhage is hyperdense. Very, very important to identify the hemorrhage. Why the infarct is hypodense is because of the water accumulation that decreases the density. That means hypodense. Hypodense decreasing the density. Okay. Next one, so these hemorrhages here, the biconvex shape, idly shape, EDH. The one which is crescent shape, which is the sickle shape, crescent shape, not limited by sutures, is SDH, which is because of the venous bleeding, the cortical bridging veins. And this one here, where you see a chronic EDH, chronic hemorrhage will be hypodense, right? So question here that you have asked, chronic hemorrhage would be hypodense. Why? Because with time, the RBCs get lysed, so the density decreases. Acute hemorrhage has fresh RBCs, so the density is high. So acute hyperdense, chronic hypodense. Okay. This one here, the white in the sylvian fissure, the white in the cisterns, all the cisterns showing the white color. Cisterns, fissures normally should contain CSF. When it is replaced by blood, CSF and replaced by blood, it is, where is the CSF present? In the subarachnoid space. So that is subarachnoid hemorrhage. The patient will present with thunderclap headache, worst headache of life. What is the first investigation that we should do in subarachnoid hemorrhage? It is non-contrast CT. Okay, it is non-contrast CT. Further to evaluate, then we can do CT angio to look for the aneurysm. Okay, to look for the aneurysm. So this is subarachnoid hemorrhage, right? Going to next one. So remember, guys, in neuroradiology, it is the infarct, the hemorrhage, all the types of hemorrhages which are like of utmost importance. Yes. Going to head and neck images, very, very important. Now, this was asked in the recent FMGE exam. Okay, this was asked in the recent FMGE exam. So let's say that there's a patient who comes with the swelling in the neck. We do a radiograph. And what do we see in the radiograph? This is the swelling on the left side. Now, what do you think is the swelling containing? Is it air? Is it fluid? Is it calcification, soft tissue? What do you think is the swelling containing? The swelling is containing air. Why air? Because it is black in color. Black on X-ray, black on CT is air. So air containing swelling, this is going to be laryngocele. The history given was very important. It was a trumpet blower. Okay, it was a trumpet blower, right? Similarly, on the CT, you are seeing this black color, the air containing. This is the same patient showing laryngocele. Okay, so remember that laryngocele is air containing. X-ray and CT are the modalities which use X-rays, right? X-ray basically is a radiograph. So previous FMG question, which modalities use the same? They are based on the same principle. It is the radiograph and the CT. Okay, it's the radiograph and the CT. Both of them use X-rays. So both of them have radiation exposure. Ultrasound and MRI, they do not have radiation exposure. Okay, they do not have radiation exposure. So trumpet blower, air containing, this is laryngocele. Next one, again, one of the recent NEET PG question and even the FMGE question. What do you think this coin is in? Is that coin in the trachea or is this coin in the esophagus? What do you think? This foreign body, the coin that we are seeing, is it esophagus or is it trachea? I see majority of you getting this right. That's amazing. This is esophagus. This coin is in esophagus. Why in esophagus? So the concept is, esophagus is a muscular structure, so it expands, right? So if this is the coin, imagine this is the coin and it is going into the esophagus. This is the esophagus collapsed. If the coin comes, the esophagus can expand and the coin can go straight like this. So when you see from the front, this will be a complete coin, a round coin that we would be seeing. Same thing if you see from the side, you will see only this part of the coin, that's a slit. So in the frontal view, the AP view, the coin is rounded like you see here. Samne wale view mein, the coin is rounded. Lateral view mein, the coin is slit-like. So this is esophagus. Okay, this is esophagus. Trachea mein what happens? The trachea is this much and the trachea cannot expand. So the coin will have to adjust according to the trachea. The trachea is not giving in. The coin says, okay, let me adjust. And then the coin will twist and the coin will go like this. So from the front, when you see, it is slit-like, and lateral, it would be complete. So that is what we see in the frontal radiograph. If it is slit-like, In the lateral radiograph, if it is rounded, this is the coin in trachea. Okay, this is the coin in trachea. And also another clue here that we see here. Out of trachea and esophagus, which is posterior, trachea in the front, esophagus behind. So this air column that you can see, this is the trachea. This is basically the trachea here. This is the air column. So trachea ke piche we are seeing the coin. In the prevertebral location, esophagus is posterior. So that is the esophageal coin. This is not in the trachea. It's not in the air column. We can see the air column separately. So this is the esophageal coin. Okay. Going to next one in the head and neck, very, very important. This is the hyoid bone, the epiglottis, which appears like a thumb. So that is the thumb sign, the inflamed epiglottis. That is epiglottitis. Okay, that's going to be epiglottitis. This one here has been asked in the previous exam, which looks like a steeple. Steeple means the pointed end. The pointed end basically tells you that the airway from this has become this. There is narrowing of the airway like a steeple. This is the steeple sign, which is seen in croup. That is laryngotracheobronchitis. Okay, that is laryngotracheobronchitis. Here there would be history of drooling of saliva. Here there would be history of barking cough, right? So that is epiglottitis and LTP, the croup. Okay. So that was about head and neck, right? I hope everybody is there, all awake and all alert. Again, a quick thumbs up in the live chat and on the video so that I know that you guys are there and listening, all of that. Yes, so this video is going to be available for later viewing as well, guys. So we are trying to just revise quickly whatever possible. So that's why we are going a bit quick. Because post this, when the video would be available, you have your own choice. You can watch it at a slower speed. You can watch it at a faster speed as well, right? Okay, so let's go to the next one. That is the chest respiratory system. Doing first the respiratory system. Okay. Now these are the most important. Devtaru, what ice cream cone sign in neurology? Are you talking about the ice cream cone sign of NF2 or the ice cream cone sign of the incus and the malleus wala joint? Vestibular schwannoma wala, that's the one of the ice cream cone. Are you talking about that vestibular schwannoma wala, the ice cream cone sign? Yes. So that is NF2 has bilateral vestibular schwannomas. So you would see that bilaterally in NF2. So what happens in that? Just let me solve his query here. So vestibular schwannoma, the vestibular nerve in the internal auditory meatus, right? So we have the cerebellopontine angle, the cerebellum, the pons, and this is the angle. And we have the internal auditory canal, right? We know that laterally going from the pontomedullary junction, we have the 7th, 8th nerve. So if there is a schwannoma here, it's going to be narrow within the IAC. And when it comes out into the angle, it comes out of the internal auditory canal, it gets all the space to expand. So it expands like this. So the narrow part and then the bulging part, that gives the ice cream cone sign. Okay, that gives the ice cream cone sign. Okay. Right. So let's have a look at this first. The 3 pleural pathologies, very, very important. First one, with this S-shaped curve, with the blunting of the angle, appearing white, telling you that it's fluid, it's not air. This one is pleural effusion. What is the most sensitive investigation for pleural effusion? Always remember for fluid. For fluid, remember U for ultrasound. For fluid, it is ultrasound. For calcification, C for CT. For fluid, it is ultrasound. For calcification, it is CT. And the remaining, the soft tissues is MRI. Okay. What is this? Is this pleural effusion? No. Why? Because this is a horizontal level. Whenever you see horizontal level, think of the air above and the fluid below. The air fluid level is horizontal. Imagine that the air is causing the pressure on the level and making it horizontal. So whenever it is horizontal, it's air and fluid both. So that is pneumo and hydro both. So this is hydropneumothorax, which has this horizontal level. And this one here, the last image that we are seeing, the last image here, This entire black thing, this is a pneumothorax. Why this is not a normal lung? Because in the normal lung, I see this white vascular markings. I am not seeing the vascular markings here. It is jet black, just air without the vessels. And this white part, the pneumothorax compressing on the lung and causing the collapse of the lung. So the lung appears more white. Okay, the lung appears more white. So this one here, this is a pneumothorax that we are seeing, and this is the collapsed lung. Classically, the lung collapses towards the hilum. What is the most sensitive investigation for pneumothorax? Pneumothorax, for air, remember it is CT. For air, it is CT. Remember ACT. ACT is for air containing pathology CT. C for calcification. For calcification, it is CT. Okay. So this is pneumothorax. What will be the immediate management? This is the most important image in the exam. It is the needle puncture. Okay, that's the needle puncture. 5th intercostal space in the adults, 2nd intercostal space in children. Needle puncture is the first one. Okay. Next one, what do you think is this image showing? This is a CT scan. Right, the lung window, and this is the lung ka margin that we are seeing. Look at how you can see the vessels in the lung. You can see the white vessels in the lung, and this one is all black air. Black is air, that means it is pneumothorax. There are no vascular markings. So this is right-sided pneumothorax. You can see the visceral pleural line. That means it is outside the lung. So this is not bronchiectasis. Bronchiectasis would be within the lung. This is outside the lung. This is pneumothorax. Okay. What sign do we see in E-FAST? The M mode of ultrasound. E-FAST has been extended to include the thoracic cavity. Another important question. E-FAST is ultrasound. We see the barcode or the stratosphere sign. Remember, we see the barcode or the stratosphere sign. The normal is the seashore sign. Seashore sign is normal. Okay, seashore sign is normal. Okay? Done, everybody? Let me increase the video quality at my end. Okay, all right. Let's go to the next one. So now we have seen just the pleural pathologies. Now we are coming to the parenchymal pathologies. First one, this is one of the recent images that has been asked. So I've tried to include all the recently asked images so that your previous year questions are also done with this session. Okay. The question here is, this pathology that you are seeing is which lobar pathology? Is it the right upper lobe, left upper lobe, right middle lobe, lingula, or the right lower lobe? What is that? This is the pathology, the white area that we are seeing. What border is it touching? It is touching the right heart border, right? It is obscuring, it is touching and in contact with the right heart border. So this is, whenever it is the right heart border which is gone, the Silhouette sign. If it's the right heart border gone, it is the right middle lobe. Okay, that's the right middle lobe. Also, if it's the left heart border which is gone, also if it's the left heart border, remember we don't have any left middle lobe. Corresponding to the right middle lobe, we have the lingula. Okay, that's the lingula that we have on the left side. Okay. What is this image showing here, guys? What do you think is the diagnosis here? These are all the air containing tubular structures, some appearing like, you know, the tram track sort of thing, some appearing circular in cross section. When I take a cross section of a tube, it would be rounded. So this is what is bronchiectasis, which is within the lung parenchyma. What other sign are you seeing here in bronchiectasis? You have the dilated bronchus with the small vessel there. That is called as signet ring sign. So remember, in bronchiectasis, generally it is the elderly patient with cough. The lower lobes are commonly involved. Okay, the lower lobes are commonly involved. So that is bronchiectasis, the tram track, the signet ring sign that we are seeing. What do you think is this image showing? What is this image showing? This image is showing this bilateral bulky hila. It's because of the lymph nodes, because these are rounded opacities. So whenever in the question you have that clue, which is bilateral mediastinal or bilateral hilar lymphadenopathy. Whenever you have this keyword bilateral hilar lymphadenopathy, think about sarcoidosis. Always think about sarcoidosis, bilateral hilar lymphadenopathy, Garland sign, 1, 2, 3 sign, right? All that we see in sarcoidosis. Okay. Next one, tell me, what do you think is the diagnosis in this image? Is it the right upper lobe collapse, right upper lobe consolidation, right middle lobe collapse? What do you think is this image showing, the upper one? Very good. Amazing. So you guys have already become like the half radiologist. So this is a collapse. First of all, collapse, does it appear black or does it appear white on X-ray? Collapse appears white on X-ray. Why? Because collapse means like this collapse. That means the air has gone out. The air is absorbed. So there is no black air. So collapse is white. Even consolidation is white because consolidation means solid lung. So from the air containing, it has become more solid. So density increasing, it is white. So how do we differentiate its collapse or consolidation? Is by the shift of the structures. If it was consolidation, the horizontal fissure on the right side would have been horizontal. Here what we are seeing that the limiting fissure, which is actually the horizontal fissure, has been pulled upwards. Collapse pulls the structures towards itself. That is same-sided shift is what we are seeing. So that is why this is right upper lobe collapse. Okay, this is right upper lobe collapse. It is not the consolidation, it's the collapse. You are not seeing the proper, like you're not seeing the S sign here. The golden S sign is where you would see the fissure ka shape, which is S. This is not the S. This is a routine concave that tells you that it is, okay, it is not because of the mass there. Okay, it's not because of the mass. Okay. Now, this is a previously asked, one of the recently asked images in the FMG exam. So everybody should know this. You can see some opacity. Let me mark it here. What do you think is this image showing? Very good. Amazing, MS Sayantan, very good. So this opacity that we are seeing, which has this classical, like a wedge shape opacity, which is overlying the heart ka shadow, overlying the heart. So whenever you see this wedge shape opacity, a wedge shape opacity overlying heart in the lateral chest X-ray, always think about the right middle lobe opacity. Wedge shape, so it is collapse. Why? Because there should have been, what should have been here? The horizontal fissure should have been horizontal. It has gone down. Okay, it has gone down. So horizontal fissure going up is the right upper lobe collapse. Horizontal fissure going down, it's the right middle lobe collapse. That is how we'll differentiate the upper lobe from the middle lobe. And this is the right middle lobe collapse seen as a wedge shape opacity in the lateral chest radiograph. Okay. Next one, important. What do you think is this image showing? No, this is not miliary. This is not TB. Very good, Pratibha. I can see Pratibha getting this right. I can talk about the heart failure. Yes, very good, Adil. This is the bat wing appearance. What do we see is the bilateral symmetrical opacities is what we can see. More in the central part of the lung, the upper lobes, the apices are spared, the costophrenic angles are spared. It's the middle part which is involved. So this is the heart, and we have the bilateral symmetrical opacities fanning out. This is the bat wing appearance, which is seen with pulmonary edema. Which pulmonary edema? It could be cardiogenic as well. That is because of the heart failure. It could be non-cardiogenic as well, which is basically ARDS. So remember that this can be seen with heart failure and also with ARDS, which is non-cardiogenic pulmonary edema. So it's a sign of pulmonary edema, the bat wing appearance, right? Going to next one, this has been the favorite with the examiners. What is this image showing? So where we don't see the left hemidiaphragm, we see those cystic, the air-filled spaces in the left hemithorax, causing the mediastinal shift to the right in a neonate. This is congenital diaphragmatic hernia. There would be respiratory distress in the newborn. On auscultation, because the heart is shifted to the right side, we might feel that the child has dextrocardia. So I've seen that in practice, that being diagnosed as dextrocardia initially, when we do the imaging, we get to know the heart is to the right side because of the push by the bowel loops. Congenital diaphragmatic hernia, respiratory distress, all the bowel loops going up. It is going to have scaphoid abdomen. The bag and mask ventilation is contraindicated. No bag and mask ventilation to be done. Okay. So that was about the respiratory system, where we first saw the pleural pathologies and then we saw some parenchymal pathologies. So we are coming from above down. If you see, first we have done the general part, the anatomy, then the investigations, then the neuroradiology, then the head and neck, and then the chest. In the chest, we have done the respiratory system, right? So we have much more to cover. I hope all you guys have all the enthusiasm and the energy to look at the more radiology images, right? Everybody a quick thumbs up so that I know, and that motivates me more than that. Yes. Okay, amazing. So going to the cardiovascular system. Okay, going to the cardiovascular system. First one, what do you think is this image showing? So the contrast is not very good with this image, but let me see if I can show you that. You can see that there is some density sort of thing which is overlapping, like over the heart, we are seeing some density. Right. So this is the enlarged left atrium. Okay, this is the left atrial enlargement. The left atrium has come to the right side, and there is this prosthetic valve that we can see. If I need to highlight here, this is where the prosthetic mitral valve is shown. That gives me a clue that the patient has been operated for mitral stenosis, rheumatic heart disease, most common. And this one here above the mitral valve, this is actually the left atrium which has come to the right side. So this is on the right side, the right atrium, the left atrium. That is the double density sign. Okay, that's the double density sign of left atrial enlargement. Remember that it's left atrial enlargement that causes esophageal compression. Why? I will show you in the upcoming image. Okay, this is left atrial enlargement, which can cause, the straightening of the left heart border. Next one. So this is an image that has been asked in the recent FMG exam, identifying the chambers of the heart on the CT scan. So this is the vertebra white. In front of that, we have this aorta. And this is the heart. Let me draw the heart here. So now I'm dividing the heart into the 4 chambers. So this side, which is actually your right side, is the left side of the patient. This is the right side of the patient, right? The chamber of the heart, which comes immediately behind the sternum, that means anterior-most chamber is the right ventricle. Okay, that's the right ventricle. So if this is the right ventricle, उसके बाजू में जो chamber है वो होगा right atrium, right? So this is the midline of the heart. So on our left, that means it's a patient, right? The right ventricle, the right atrium. So this is the left ventricle, this is the left atrium. So which is the posterior most chamber of the heart that we are seeing here? That's the left atrium. Posterior most is the left atrium. You can see these structures going into the left atrium. These would be the pulmonary veins. Okay, these would be the pulmonary veins. And what are we seeing behind the left atrium? Left atrium एक side पे, aorta एक side पे. This is what is esophagus. And that is why when the left atrium enlarges, it compresses on the esophagus. So esophagus, left atrium enlarging, compressing on the esophagus, right? So this is esophagus. Transesophageal echocardiography is for which chamber of the heart? Through the esophagus, I will see the left atrium and I can also see the aorta. So it is also done for aortic dissection, especially if the patient is unstable. Okay. So these are the various chambers of the heart that we should be knowing. Next one. Now, what is this image showing? This is where your favorite I was seeing in the live chat. This is the money bag heart or the flask shaped heart or the water bottle heart. Imagine a bag, a potli which is kept and it is spreading, right? It's spreading like this. So a flask shape or the water bottle heart or the money bag heart. This is water. Water means effusion. So this is seen with pericardial effusion. That is what we are seeing in this CT also. This is the heart, and surrounding the heart, again, look at this gray color. Have this image in your mind. Gray color is water on CT. So surrounding the heart, this gray color water, this is going to be pericardial effusion. What is going to be the most sensitive investigation for pericardial effusion? Pani hai, fluid hai, fluid is ultrasound. Okay, fluid is ultrasound, right? Yes, very good, Arya. That gives the Oreo cookie sign on the lateral radiograph. Ultrasound of the heart is nothing but echocardiography. Echo matlab sound. Sound means ultrasound. So when I say it's ultrasound, indirectly that means it is echocardiography, which is the most sensitive. Okay? Cardiac tamponade, ordinary threshold. See, tamponade is which it is compressing the heart, right? So you would see the compression, that means the wall being compressed by the cardiac tamponade. It's more of an acute collection. Okay, it's an acute collection that is happening. Okay. Let's have a look at this one, guys. Tell me, what do you think is the diagnosis in these images now? What do you think is the diagnosis in these images? Right. This has been asked in the FMGE exam previously. This is constrictive pericarditis. Okay, this is constrictive pericarditis because I see the white calcification. Look at this white lining around the heart. Look at this white lining, that is calcification. Look at this white calcification, right? And look at this white calcification surrounding the heart. So that is calcific constrictive pericarditis. Question asked this, JVP में क्या दिखेगा? JVP में, remember, it is M pattern. What is the M pattern? The X descent is present. It is a Y descent which is prominent. Okay, it's a prominent Y descent with the X descent also present. That is constrictive pericarditis, right? It gives the egg and cup appearance on the chest X-ray. Egg on string, nahi, it is egg and cup. Okay, this egg and cup appearance. Egg on string, egg on side is TGA. Okay, coming to the very favorite, the congenital heart diseases was also asked in the recent INI-CET exam. The first one here with the apex going up. This is the boot-shaped heart. It's because of the RVH, which is because of the tetralogy of Fallot, right? Tetralogy of Fallot. Next one, this has been asked in recent NEET PG exam. This is the figure of 8 appearance or the snowman appearance. Remember, snow falls from above. Snowfall upar se hota hai, niche se nahi hota hai. So snow is upar se, that's a supra. Upar se yani supra. It is seen in supracardiac TAPVC. This one here, which is the egg, which is on side with the narrow superior mediastinum, egg on side, egg on string. It is the transposition of great arteries. Imagine the egg which has been transpositioned on side. So it is transposition of great arteries. Check for maternal diabetes mellitus. Okay. And this one here, where there is significant right atrial enlargement, this is the box-shaped heart. When I open the box, it opens on 3 sides. The tricuspid valve pathology, that is Epstein's anomaly. Epstein's is box-shaped heart. It is because of lithium, teratogenic effect of lithium. That is the box-shaped heart. That is Epstein's anomaly. Okay. So that was about the CVS. We have seen the pericardial effusion, constrictive pericarditis, congenital heart defects, the chambers of the heart, and the left atrial enlargement. That is the double density sign. So without me saying, after every system, there has to be thumbs up and the likes on the video as well, because I told you that it's a permanent thumbs up that I would be seeing, right? Yes, Amrita, definitely not just pass, but with flying colors you would pass. Okay, let's go to the next one now. That's the GIT, right? So we are done with the neuro, the head and neck, the chest, and then going to the next part, that is the GIT, then the genitourinary. Okay, GIT may cannot skip this image at all. It's very, very frequently asked. This is pneumoperitoneum. Why pneumo? Pneumo means air. Air on X-ray, air on CT is black. Okay, that is black. So air beneath the diaphragm, free air beneath the diaphragm. This is what I see here. That is why it's pneumoperitoneum. This is the CT scan, which is showing this free air anteriorly. This is the air beneath the anterior wall. So this is pneumoperitoneum. The best X-ray view is chest X-ray. If the chest X-ray, erect. If the patient cannot stand erect, that means we can ask the patient to lie down on one side. That is decubitus view. Which decubitus? Remember, it is left lateral decubitus. Left lateral decubitus. And with which beam? The horizontal beam of the X-ray. It is left lateral decubitus with the horizontal beam that we can do. What will be the most sensitive investigation for pneumoperitoneum? It's going to be CT because it is air containing. Air is CT. Should we do barium studies in these cases? No. Very, very important point. Remember that barium is contraindicated in perforation. In any perforation, barium is contraindicated. So what contrast we can use? Iodinated contrast, which is a water-soluble contrast. Use iodinated contrast. Which one is preferred? The low osmolar non-ionic iohexol preferred over gastrographin, which is high osmolar. So iohexol is preferred over gastrographin. And what would be the management? That is the question which is asked. Pneumoperitoneum, most likely it's perforation. So we need to do exploratory laparotomy surgery for the patient to repair the perforation, right? Next one. This is like the most favorite with the examiner somehow, the barium swallow for the esophagus, showing that bird beak appearance. The dilated esophagus with the narrowing in the lower part, that is achalasia. Okay, that's achalasia. What is the gold standard investigation for achalasia? It is manometry. I need to measure the pressure in the LES to prove that the pressure is high. Manometry. Okay, so achalasia showing the bird beak sign. What is the next image showing? That's the corkscrew esophagus, the multiple spasms in the esophagus that you can see. So this is diffuse esophageal spasm. That is the corkscrew esophagus, again asked many times. Another favorite image, one bubble and two bubbles. That is what we see. Nothing else in the abdomen, no other air. So there are only two bubbles, double bubble appearance. So double bubble, the stomach and the duodenum. So this is seen with duodenal atrasia. Duodenal double bubble, right? Or it can also be seen with annular pancreas. Okay, it can also be seen with annular pancreas, where annular pancreas compresses the duodenum. So simulating duodenal atrasia. Okay. Next one here, where we see this coffee bean sign, right? The three longitudinal lines converging at this point, the coffee bean sign, very, very important. Coffee bean is sigmoid volvulus. Okay, it is sigmoid volvulus. Sigmoid volvulus, is it with hostrations or without hostrations? You don't see any hostrations in sigmoid. It is ahostral. Cecal volvulus is something which is, cecal volvulus has the hostrations. Okay? What is this image showing here and what is the investigation here, guys? What is the investigation and what is the diagnosis? The investigation is the barium enema. It is not in the small intestine. And this is the narrowing in the colon. This is still, we are in the transverse colon. This is the narrowing that we are seeing like the apple core. So barium enema showing the apple core appearance. So remember that apple core is seen in carcinoma. Okay, that is carcinoma colon. That is the apple core appearance. When we eat the apple, the core has an irregular surface. It is narrowed. So that is apple core. Okay, apple core carcinoma. Next image in the GIT, very, very important. What do you think is this set of images showing? Let's see who's answering it the first. Very good, Dr. Shabir and Nupur, Dharamveer. Correct. This is CHPS, now also called as IHPS, the idiopathic or the congenital hypertrophic pyloric stenosis. What is this investigation? This is barium meal containing the barium in the stomach. What are we seeing? The narrowing of the distal part of stomach, that is pylorus. Anywhere in radiology where there is narrowing, it is called as the string sign. Okay, that's the string sign that tells you that it is narrowed pyloric stenosis. Going into the duodenum, appearing like a mushroom. So this is the mushroom sign. Okay, that's the mushroom sign, string sign, CHPS. Question asked here in the recent NEET PG exam is, what is the investigation of choice? What is the investigation of choice in this case? Investigation of choice is going to be ultrasound because it's a child. So in a child, prefer ultrasound first because it has no radiation exposure. Plus, ultrasound will help us see the hypertrophy, whether the muscle layer, remember it's a hypertrophy of the muscle layer that we want to see. The muscle layer hypertrophy should be more than 4 millimeters, thickness more than 4, length more than 16. So remember 4 and 4 square, 4 and 16, right? So this is the stomach on the ultrasound. This is the elongated pylorus. This is the wall of the pylorus, which is thickened. One layer, it should be more than 4 millimeters. When I take a cross section of this pylorus, transverse the section, I would see the narrow pylorus and I would see the thickened wall. The hypoechoic is the muscle which is thickened, which should be more than 4 millimeters. That is the target sign or the donut sign. Okay, the target or the donut sign. Yes, the differential diagnosis is pyloric spasm. In that case, the muscle layer will be less than 4 millimeters. The acid-base disorder that it will lead to is metabolic alkalosis because the acid is going out. The first management has to be electrolyte imbalance correction, and then we do the surgery, that is Ramsted's pylorotomy. Next in the GIT is this very, very important set of images, which is intersusception. Okay, intersusception, a child presenting with red currant jelly stools, and we see some mass on the radiograph, some vague mass, opacity is seen. We do the ultrasound. Ultrasound is the investigation of choice. Again, no radiation. What will we see in intersusception? Inner bowel, outer bowel. That again is the target or the donut sign. And we also see this target sign here on CT scan. What do we see on the barium enema? The barium going up, the barium going up. And when it reaches the site of intersusception, intersusception is one bowel going inside other. So this barium going up, it forms a claw around the intersusception. So that is the claw sign. Okay, that is the claw sign that we see with intersusception. Frequently asked, recently asked question. Now imagine that there is some space between the outer and the inner bowel. The barium will go in between the two, outlining the intersusceptum. So just the outline of the barium is what we would see. This is a previously asked NEET PG question, that is coiled spring appearance. Okay, the next one is the coiled spring. So remember that it is claw sign and the coiled spring sign that we see here. What will be the management? The air enema, pneumatic reduction, or the hydrostatic reduction is the first thing that we should do in these cases. Okay. Last one, I believe, in the GIT that we have. What do you think is this image showing? So this is the sawtooth appearance. This is the sawtooth appearance basically that we have. So previously asked question again, where do you see the sawtooth appearance? It is diverticulosis. The colonic diverticulosis, the diverticuli, the outpouchings appearing like the sawtooth. So that is sawtooth appearance, diverticulosis. Recently asked question again. The next one is the hepatobiliary. We are done with the GIT part per se. Now coming to uska rishtedar, that is the hepatobiliary. First one, ultrasound showing this gallbladder. You can see that the gallbladder is black because remember that fluid is black on ultrasound. That means anechoic. And in the gallbladder, we see those white calculi. How do I know it's calculi? Because it is showing the posterior acoustic shadowing. So this is gallbladder calculi. Okay, GB cal, cholelithiasis. Tell me, what do you think is the diagnosis in the next image, guys? What do you think is the diagnosis in the next image? Very good, amazing. So superb. This is the comet tail artifact. So remember that comet tail artifact in the gallbladder. Comet tail, COCO, is cholesterosis. Okay, that is cholesterosis. That is adenomyomatosis of the gallbladder. That's a comet tail sign. Tell me, what investigation is this one? The third image here. What investigation is that? Very good. Correct. Vikram, absolutely right. That is ERCP. Yes, Dr. Shabir Rishabh. ERCP, you can see that here the endoscope is appearing black because it's a fluoroscopy image. It can be black, it can be white. And in this ERCP, what do you think is the diagnosis? Let me zoom this image for you so that you can see at this one. So look at this. You know, the dilatations, the strictures and the dilatations, that is the beaded appearance that we are seeing there. Okay, that is the beaded appearance that we are seeing there. Beaded appearance, strictures, multiple strictures. This is primary sclerosing cholangitis, which shows the onion peel appearance on histopath. Always remember the association with ulcerative colitis, right? There is a pruned tree appearance also. The peripheral branches are gone. Pruned tree, beaded appearance, ulcerative colitis. It is primary sclerosing cholangitis. Okay. This has been asked previously multiple times, FMGE also, and the NEET PG exam also. Now, when you see this gray density again, it's gray color. That means it is fluid containing. In this location, like just in front of vertebra retroperitoneal, very good, Harshit. That is pseudocyst. Okay, that is the pancreatic pseudocyst. Acute pancreatitis, pseudocyst formation is what we are seeing here. Tell me, what is the next image showing, guys? What is the next image showing? So we can see that white on X-ray is calcification. So it is calcification in the pancreas. Look at the direction. It's a pancreatic calcification. Calcification in pancreas, it is chronic pancreatitis. Okay, it is chronic calcific pancreatitis. Calcification in pancreas, always remember C and C. Calcification is chronic, and remember the another C. We see the chain of lakes appearance. Okay, we see the chain of lakes appearance with chronic pancreatitis. Okay. Now going to the next one. Right. So what is your task after every system? We are done with the GIT. We are done with the hepatobiliary and the pancreas wala part. The next is the uroradiology. Very good. So you guys are smart. So going to the next one, uroradiology, quickly having a look at the images. First one, very, very frequently asked, what investigation is this? This is IVP. I see the kidney, I see the ureter. So that's IVP there, bilaterally seen. And there is the dilatation at the distal ureter end, the ureteric insertion. So this is the cobra head. Okay, that's the cobra head or the adder head appearance. The ureter coming, dilatation like the cobra head. So dilatation is the seal. Seal means dilatation. So that is ureterocele. Remember, it's ureterocele. It's not the uterocele or the urethrocele. Ureterocele. What is the next image showing? Very good, Kundan. That is the Christmas tree appearance. Okay, that's the Christmas tree appearance. So Christmas tree, yes. So on the Christmas Eve, we have the Christmas tree appearance. So Christmas tree is basically the elongated bladder with a lot of diverticuli that we see. Okay, that is the diverticuli. This is seen with neurogenic bladder. Okay, neurogenic, the tone is affected. So from the round bladder, it becomes elongated bladder. Neurogenic bladder is not getting empty. So a lot of urine accumulating, has to find a way. So it goes into the diverticuli. So the bladder develops diverticuli. So elongated bladder due and multiple diverticuli is neurogenic bladder, Christmas tree bladder. Okay, that is Christmas tree appearance. Next one, what is this ultrasound is showing? This is an ultrasound image. This is the kidney. Okay, that's the kidney. Tell me, what do you think is the diagnosis here? Khalid, I'll share this entire PDF on the Telegram group. Okay, I'll share it on the Telegram group for your last minute revision. No, don't look at this image. You just have to look at this image. What are we seeing here? So this is the white area, again with the posterior acoustic shadowing. So this is calculus. This is nephrolithiasis. That is causing hydronephrosis. Again, I see the black fluid, hydronephrosis. This is nephrolithiasis, renal calculus with the hydronephrosis. This image is the staghorn calculus. Staghorn, and look at this one. This is a plain radiograph showing the staghorn calculus. The staghorn calculus. Remember that. Okay, remember that it is the X-ray which will show the staghorn calculus. It's a triple phosphate. Staghorn is triple phosphate, right? True white stone. What crystal do we see? What is the appearance of the crystal with the true white stone? Triple phosphate, true white staghorn. What is the appearance of the crystal? Very good. Remember, true white. White clothes. When do we wear the white clothes? In a funeral. That is coffin lid. Okay, that is coffin lid. So remember that the white coffin lid, it's the coffin lid appearance. Okay, coffin lid appearance. Next one. Now, this was asked in one of the recent NEET PG or INI-CET exam. And the question was, this is a child and this is the IVP image with a delayed IVP image which is given. A child with delayed IVP. What do you think is the diagnosis here? Let me go back to the image. So what do we see here is more than the drooping lily. Look at the other kidney here. You can see the kidney, pelvic ileal system, the ureter. This is just the kidney that I can see. I don't see the ureter. That means this is the hydronephrotic kidney. I can see the dilated pelvis and the calyces, which is blocked here. That means the contrast is not able to go down. So yes, this is the PUJ obstruction. Correct medical read. So this is pelvic-ureteric junction obstruction. So PUJ obstruction, delayed IVP is the clue. Ureter not seen on the delayed images. That is PUJ obstruction. Okay, so pelvic-ureteric junction obstruction. Next one, if this is the ultrasound image of the kidney and you are seeing a mass in the kidney which is hypoechoic or hyperechoic. Hyper, it is white, so hyperechoic. What is hyperechoic on ultrasound? It is fat. If it was cyst, it would be black, fluid containing. So what is the fat containing lesion in the kidney? It is angiomyolipoma. What are you seeing in the CT here? The bilateral lesions here in the kidney which have those dark, dirty black appearance. It is not the jet black appearance. The dirty black appearance is of the fat. This is angiomyolipoma. Remember the point that fat has negative HU value. It is less dense than water. That is why it appears dark on CT. So the dark lesions in the kidney, especially if it is bilateral angiomyolipoma, think about tuberous sclerosis. Okay, think about tuberous sclerosis when you have bilateral AMLs. Again, this is a favorite and has been asked in the recent exams. right? And this was the image asked in one of the recent FMGE exam. What do we see here? First, identify this investigation. This is CT with the white bone. This is the black vertebra. So this is MRI. So the question asked was, identify it is CT or it is MRI. Now in the CT, we are seeing those multiple small lesions, which on MRI are appearing white. That means water white T2 wala. This is bilateral kidneys, polycystic kidney disease. You can see a cyst in the liver also, right? So this is CT showing polycystic kidney disease. This is MRI showing polycystic kidney disease. Okay. So remember the differentiation between CT and MRI. What is this structure here? Anyone, what is this structure here that you are seeing? Medial and behind the kidney, that is going to be what muscle? That is the psoas muscle, which can be affected in TB. TB mein hota hai psoas abscess. So whenever it's psoas abscess, we think about TB. Okay. Right. So we are done with the uroradiology part. Right. So hum upar se aaye hain. We have reached to the kidneys and now we are going still down. That is the OBGY part. That is the uterus and the ovaries part. Okay. Right. I know that this is like not even a marathon. It's a sprint that we are having. Rapid revision of all the important images in radiology. Right. So keep the spirits high. Thank you, guys. Let's go to the next one. Very, very important images in OBGY. What is the first one showing? This is all the cystic spaces that we are seeing. If I tell you that this is a patient who's beta HCG positive, increased levels of beta HCG, this is all the cystic spaces. Those are the vesicles, the bunch of grapes appearance. So this is the snowstorm appearance, which is seen with H-mole, complete H-mole, complete molar pregnancy. We just see the cyst, no fetal part. What is going to be the treatment? Do we continue? No, it is suction and evacuation that we need to do, right? Next one, what is this image showing? What is this, the next image showing? So thoda pani to banta hai, right? No, that's not the uterus which is shown here. This is basically the placenta. Okay, this is the placenta going in between the two fetus. So what we see there is the lambda sign. Okay, that's the lambda sign. So where do you see the lambda sign? So look at this one. What is the first image showing? Laddu, right? So what is Laddu telling you? Laddu is telling you that lambda sign is seen in DD, that is dichorionic, diamniotic. So Laddu is lambda sign is dichorionic, diamniotic. Okay. Next one is our respected Prime Minister Modi ji, who's the most famous chai wala in the country. That's the T. So remember that the T, the chai, the T sign is seen in Modi. What is Modi? It is monochorionic, diamniotic. Okay, that's monochorionic, diamniotic. That is where you see the T sign. So this is the lambda sign that we are seeing. So that is Laddu. And we have the T sign, which will be seen with monochorionic, diamniotic. So remember Modi, monochorionic, diamniotic. You don't have a pregnancy which is monoamniotic and dichorionic. Okay. So this is lambda sign, DCDA, which is also called as the twin peak sign or the lambda sign. Okay. Next one, again, a very, very favorite with the examiners. This is in the sagittal section of the fetus. We are not seeing the bone here, right? So this is anencephaly, right? That's anencephaly. This is also anencephaly, which is showing these eyes, the frog eye appearance. Remember that it is the earliest anomaly that can be identified on ultrasound as early as like around 10 to 11 weeks. It's the earliest anomaly. Okay. And what is the next image showing, the last image? First, identify the investigation. It is HSD, hysterosalpingogram. It's an X-ray. It's basically a contrast X-ray. We don't use saline here. It is the iodinated contrast. And what are we seeing? That the uterus is deviated to the one side. There is just one horn. That is unicornuate uterus. Okay, that is unicornuate uterus, which one fallopian tube. So this is unicornuate uterus deviated to one side. That is called as banana uterus. Deviated to one side, banana uterus, unicornuate uterus. Okay. So done with the genitourinary. Those are the most important images that we need to know. Right, the details of septate, bicornuate, सब कुछ यहाँ पे नहीं होगा, वो हम बाकी कोई सेशन में देखेंगे. ठीक है, amazing. So you guys are so obedient and so smart. You know that what is to be done. So musculoskeletal system. Going to the next one, the musculoskeletal system. Very important image. The first one here, where you see the skull, the bone is thickened, diploic space is thickened, and there is those hair on end appearance, hair on end, crooked appearance. It is seen in any hemolytic anemia. Remember, it's not just thalassemia. It is any hemolytic anemia which can show the hair on end or the crooked appearance. It's because of the increased hematopoiesis, hemolysis stimulating the hematopoiesis. So a lot of bones get occupied, involved in hematopoiesis. So that thickens the diploic space and there is hair on end appearance. Any hemolytic anemia, be it the sickle cell, G6PD, thalassemia, they can give this. Next one, another favorite with the examiners, going till the joint surface, which is the bone tumor which goes till the joint surface. Joint is giant. Remember, involving the joint is the giant. Okay, so that is giant cell tumor involving the articular surface. It is expansile. It has this soap bubble appearance, the multiple trabeculations. So that is soap bubble, and this is giant cell tumor. The treatment is asked. Remember, it is extended curettage. The treatment is extended curettage. Okay, what bone tumor is this? Which is based on the cortex. There is this cortical thickening that we are seeing, and in the center there is a nidus. Cortical thickening with central nidus. Nidus is like this. Cortical thickening ke andar central nidus. Matlab O and O. What is O and O? The OO is the osteoid osteoma. So cortical thickening with the central nidus, O and O, OO is osteoid osteoma. The classical history would be increased night pain, pain which is worse at night and relieved by aspirin. Why? Because it is because of prostaglandins coming from this nidus. Important, what is the treatment for this? We want to ablate the nidus because that is what is causing pain. So it is radio frequency ablation. Okay, it's radio frequency ablation that we would do for this tumor. A recent INI-CET question. Okay. Next one, whether this is CT or this is MRI, guys, what do you think? This is CT or MRI? This is the black bone cortex. This is MRI. The CSF is white. It is a T2 weighted MRI. What are we seeing here? A collection which is formed. There are two vertebrae that are involved. देखो vertebra है, posterior element है, vertebra है, posterior element है, vertebra posterior element, vertebra posterior element. So if you see, basically it is at least two levels that are involved. That means obviously the intervertebral disc is involved in this case, right? So intervertebral disc, whenever the intervertebral disc is involved in spine, always think about Pott's spine. It involves the intervertebral disc. Metastasis will not involve the intervertebral disc, right? So this is Pott's spine, which can lead to psoas abscess, right? Psoas can be involved. Then, now coming to the most important, we are on the last part of our discussion, the emergency images. Right, so kindly mark the L5S1. See, ideally, we should not be marking L5S1 and only this part. Whenever we do the spine MRI, we do the entire screening, the entire spine, we start counting from above. Why? Because sometimes there can be sacralization and sometimes there can be lumbarization. So lumbar vertebra can look like sacral, sacral can look like lumbar. That is why just based on this part, we should not be labeling. बट फॉर आवर एग्जाम लेट्स से हमारे लेवल पे हमको क्या याद करना है कि जहां से ये शेप स्टार्ट हो रहा है दैट इज द सेक्रम and the above that is the L5. So L5 S1, but as I said, this is incorrect way of labeling. We have to start counting from above, right? Sometimes this can be S1, sometimes this can be L5, okay? Coming to emergency, thank you so much. Going to the next one. What is the diagnosis in the first image here? Right, correct. So we saw the SAP, superior vena cava, ascending aorta, and the pulmonary artery. So the pulmonary artery is showing this filling defect. The white contrast is not able to go into that area. That indicates it's a thrombus or it's a embolism. So this is major pulmonary embolism involving both the arteries, the main artery bifurcation. This is pulmonary embolism. What is the investigation of choice? CT, pulmonary angiography. What is the first investigation? D-dimer. That is the screening test, right? So remember that this is pulmonary embolism. What is the diagnosis here in the next image? This is the descending aorta that has been divided into two. The line dividing the aorta into two, that is dissection. So this is aortic dissection, right? This is aortic dissection. We use Stanford and DeBakey's classification. The investigation of choice is CT angio if the patient is stable, transesophageal echo if the patient is unstable. Right. What is the diagnosis here, guys? In the CT brain, we have already seen this image where the blood in the sylvian fissure, the white blood in the sylvian fissure. Very good. This is subarachnoid hemorrhage. What is the diagnosis in this image here? This is where I see the lung margin and I see this, the black plaque. This is pneumothorax. Okay, this is pneumothorax. Needle puncture is the immediate management. Okay, this is pneumothorax. Okay, and this is the collapsed lung, appearing more white, pneumothorax with collapsed lung. ठीक है, हो गए हमारे emergency वाले ये images बहुत important है. Iodine isotopes. Iodine 123, iodine 131, iodine 125. This is favorite again for the FMGE exam. Yes, great. So you're not forgetting your homework, not even homework, the live class work that you need to do after every system. So iodine isotopes, the question is asked on the half-life. Let's have a look at the uses first. 123 is used for diagnosis, that is radioactive iodine uptake scan. 131 is the one which is used for treatment, the radioiodine ablation that we talk about in Graves' thyroid cancer. Where is iodine 125 used? It is used as brachytherapy, seed implant, most commonly in prostate cancer. Okay. Now thinking logically, the one which is used for diagnosis has the minimum half-life, because it's only for diagnosis. We don't want the radiation to be there for a long time. So this is the one that will have the half-life in hours. The 1 and the 3, that is 13 hours. The rest of them which are therapeutic treatment ke liye, they have the half-life in days. Okay, they have the half-life in days. 131, 1 plus 3 plus 1 plus 3. That makes it how many days? That makes it 8 days. 125, 12 into 5, that makes it how many days? That makes it 60 days. So 131 is 8 days, 125 is 60 days. The therapeutic effect of 131, remember, is because of the beta rays. It is not because of the gamma rays. Okay, it's because of the beta rays. All right. So that's about the iodine isotope. So always remember this point, general point, that the diagnostic ones will have their half-life in hours. Example, we said that for F18, PET wala, uska half-life at 2 hours, approximately 100 minutes. Technetium 99M, which is used in scintigraphy, uska half-life is 6 hours. So diagnosis walo ka hota hai hours mein. Remember that general concept so that you don't have to mug up the half-lives. Okay, so technetium is 6 hours, F18 is approximately 2 hours. Okay. All right, let's go to the next one here, radio sensitive and radio resistant. Very, very important. This is somehow the favorite in the recent years. Now, in the radio sensitive, remember the cells which are continuously dividing, those are the ones which are radio sensitive. So which is the most radio sensitive tissue? That is the bone marrow. Which is the most radio resistant tissue? That is the nervous tissue, the neurons, because they do not divide. Okay, they do not divide. So remember that bone marrow is very sensitive. The neurons are the ones which will be the least sensitive. Apart from that, the intestinal epithelium, right, the gonads, these are going to be sensitive as well. Which are the highly radio sensitive tumors? Remember the mnemonic is Wells. What is Wells? It is Wilms, Ewing's, then we have lymphoma, and the M stands for multiple myeloma and seminoma. These are the highly radiosensitive. Remember, M is multiple myeloma. M is not melanoma. Melanoma is highly radio resistant. M is the multiple myeloma, the bone wala tumor. It's not the melanoma. Remember, melanoma is very resistant to radiotherapy. So these are the highly radiosensitive tumors. At least remember these. Okay. Going to next one, the general part. Okay, now we will have the look at some of the general images. Right. So the first one here, what is this image showing? Omnipac. Okay, Dr. Jacob, Shashi, Guerra, amazing. So not forgetting on that, and Dream. Raj Vasaya, I can see you all. Thank you so much. So what is this image showing? This is Omnipac, and it is showing its iohexol. So as the term says, it is iohexol. What does that mean? It is iodinated contrast. And where do we use iodinated contrast? In any X-ray based investigation. Any X-ray based, it's a contrast X-ray, IVP, HSD, it's a contrast enhanced CT, right? So any contrast X-ray or any contrast enhanced CT, we use the iodinated contrast, right? What do we use as contrast in MRI? It is gadolinium because it's a magnetic substance. So we use gadolinium there. What machine is this, guys? What is this machine used for? Is it used for bone mineral density? Is it used for chest X-ray? What is this used for? This is a mammography machine. How do we identify the mammography? By this compression paddle. So in mammography, we compress the breast, right? We compress the breast. So it's a sort of painful investigation. Why do we compress? It's not to take revenge from anyone. You know, koi badla lene ke liye nahi hai. So it's because when we compress, the density decreases, it becomes more uniform, the thickness decreases, so the X-ray penetration is better. Okay, the X-ray penetration is better, so the images are better, right? So compression is a must for mammography. So in which conditions it is contraindicated? Where we cannot compress the breast. So any acute painful condition like breast abscess, it is not done. Mastitis, it is not done. What is the investigation of choice for breast abscess? It is ultrasound. Do we prefer mammography in a young female or an elderly female? It's an elderly female. Why? Young female, more glandular breast, it's more dense. The images will be more white, right? Elderly female, more of fatty breast, the image will be more dark. So the calcification will stand out. In the black breast, the white calcification will stand out. Okay? So that's about mammography. Look at this machine and look at this machine. These are two different machines. The one where you have a tunnel, okay? The one that you have tunnel, that is MRI. You know, if you have undergone an MRI any times, many patients feel claustrophobia there because you are put into that tunnel. Plus you have the coils also that are used based on what part MRI we are doing. So this is MRI with a tunnel. In CT, it is just this one round. There is no claustrophobia. Okay. So tunnel wala will be MRI, just a single circle. Piche ki diwal dikh rahi hai. That means it's a CT scan. So CT and MRI, that is how we clear them. Okay. That is how we differentiate them. So this is mammography. Okay, so I believe we are on the last part, and so just next 5 to 10 minutes and we are done with this rapid revision of radiology. Do not forget to revise this session before your exam, whether it's FMG or it's NEET PG. Okay, amazing. So let's go to the last mile here, the NMRT wale images. First one, can someone identify what are we doing here in this image? Let me zoom this image. For whoever is not able to see the images clearly, go to the video settings and increase the video quality. Generally, that is the glitch that we have. What do you think is this? Is this MRI? No, this is not MRI. MRI में ऐसा बंद नहीं होता है. It's not a closed door. Okay, remember, it's not a closed door, right? So where you have this closed door sort of thing, and there is a coil, a frame sort of thing that we are using. This is the treatment part, and this comes under gamma knife. Okay, this is gamma knife. What is gamma knife? Very good, Meet, correct. It is gamma knife, which is a stereotactic radiosurgery. Okay, it is stereotactic radiosurgery. So what do we do in gamma knife is, we put the frame, the Lexell frame, because who invented this gamma knife is Lars Lexell. So we put this Lexell frame around the patient's head. We do the MRI, we localize the lesion, and then we put the patient into this gamma knife machine where all the gamma rays are concentrated onto that lesion. So remember that it's only the gamma rays. There is no knife here. There is no surgery here. This was invented by Lars Lexell, who was a neurosurgeon. So I realized that kuch aise lesions hai where I'm not able to operate well. Let me find a solution. So for those small lesions, inaccessible lesions, localized lesions, he invented this gamma knife, basically for the brain lesions. We have stereotactic body radiotherapy for the rest of the body as well, which uses LINAC, the cyber knife. So gamma knife uses gamma rays. Cyber knife, there's something called a cyber knife also, which uses X-rays. Okay, which uses X-rays. This is what is this machine that you are seeing, which can rotate, right? So it can change the angle. There is this area here, जिसमें से यहाँ से electrons, X-rays आते हैं. This is what is LINAC. We do not need a frame in LINAC. Linear accelerator, it is frameless. So remember that this is a LINAC coming like an overhead thing, which can rotate as well, used for treatment. Linear accelerator, what does LINAC produce? LINAC produces X-rays and electrons. Okay, it produces X-rays and electrons. This one in the thyroid scintigraphy, where you see that both of the thyroid are very, very black. They are enlarged. Black means increased uptake. That means they are hot. So bilateral, diffuse, increased uptake in thyroid. Remember that it is Graves' disease. It is not just a nodule that we are seeing. It is diffuse thyroid, which is black. So that is Graves'. Opposite, bilateral, diffuse, decreased intake, burnt out thyroid is thyroiditis. Thyroiditis is diffuse, decreased uptake. Graves' is diffuse, increased uptake. Thyrotoxicosis. Okay. And can someone identify what is this image showing here? In this scintigraphy, what are we seeing? If I tell you that this is a patient who presented with pain, acute pain in the right iliac fossa, what do you think is the diagnosis? Very good. Dr. LRS, correct? And Nani and Prince Davis, I can see you there answering there. So what do we see here is this on the left side is the stomach. We see the uptake in the stomach. We also see the uptake in the right iliac fossa. That means that stomach jaisa, there is some tissue which is present in the right iliac fossa. Which is that right iliac fossa pathology containing ectopic gastric tissue? That is Meckel's. Meckel's has ectopic gastric, ectopic pancreatic tissue. So this is Meckel's diverticulum. So what scan do we do for Meckel's? It is technetium 99M per technate scan. Okay, it is technetium 99M per technate scan, which is done for Meckel's, which will be positive only if it contains the ectopic gastric tissue. Right? So remember that for Meckel's, it is per technate scan. Technetium 99 per technate scan. Right? And this is the gamma knife that we are seeing, the frame that we have put around the patient's head. The closed door wala, that is going to be gamma knife. Closed door wala will be gamma knife. Okay? So thank you so much everyone for joining in. We have extended beyond our time constraints, but I believe completion of this was more important so that I give you a wholesome, like one place, all the important images, the most important images. And I believe and I hope and I pray that you do get a lot of questions and images from this in your upcoming FMG exam and the NEET PG exam as well, as far as radiology is concerned. Okay. Thank you so much, everyone. And goodbye. Take care and keep studying, keep revising, and keep winning. And do not forget to show your love by just pressing the like button on this video, because I'll keep a check on that as well. This being my very first session at PrepLadder, so that is going to be something very special, right? Thank you so much and goodbye. Take care, everyone. Thank you.
Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder.